We welcome everyone to Medicine Endgame, and this is part 4. In part 1, we had seen cardiology, that was topic number 1 to topic number 24. In part 2, topic number 25 to topic number 54, we had seen neurology, and in part 3, from topic number 55 till topic number 87, we had seen GIT plus hepatology. And prior 3 topics we had finished in 1.5 hour each, so we have totally completed 4.5 hours. And now in this video, we are going ahead with endocrinology, which will again take us 1.5 hours. So this will be endocrinology only. So what you should do in addition to watching this video and going through the PDF, you should also do PYQs. PYQs plus this video will help you answer almost all questions of upcoming NEET, PG and INICET. So let's move on to first topic, that is acromegaly. So in acromegaly, pituitary gland over secretes, there is excessive secretion of growth hormone. This growth hormone increases one specific factor from liver, that is insulin like growth factor, IGF-1, and this IGF-1 is the reason behind overgrowth of the tissue, and it is not growth hormone per se. So what are the causes? Most common causes pituitary adenoma, and GH excess, IGF-1 is the mediator. So this point we had also seen in pathology when I was discussing pathology endgame videos. There also we had come across this. So what are the clinical signs? Enlarged hands, big hands, coarse faces, mandible will come forward. Okay, this is known as prognathism. So screening test is serum IGF-1. I told you, this IGF-1 is the screening test. And what is the gold standard? Gold standard is growth hormone suppression test. Means which means growth hormone will actually cause increased level of glucose. Okay, so growth hormone will increase the level of glucose. So when increased glucose is given, okay, it should cause inhibition of growth hormone. But in acromegaly, where there is GH excess, this growth hormone levels are still higher only. So failure of suppression of growth hormone when you give oral glucose is known as the confirmatory test. On imaging, you will find pituitary MRI, you will find pituitary adenoma, and you do transsphenoidal surgery. That is, you go through the sphenoid sinus, you go to the pituitary, which is sitting above the sphenoid sinus, and you resect pituitary. So pituitary adenoma. Pharmacological management includes octreotide. Octreotide is actually antagonist of growth hormone. That is, it is a somatostatin analog. Which one? Octreotide. So somatostatin inhibits growth hormone secretion. So that's how it is contradictory, has contradictory action. And one more is pegvosomant. Pegvosomant actually is a growth hormone receptor antagonist. Okay, I told you, growth hormone sits on liver and then it will cause IGF-1. So this receptor where it sits, that receptor antagonist is pegvosomant, and it will decrease the level of IGF-1. So there will be symptomatic improvement. So you should know that in acromegaly there is increased risk of colonic polyps. Okay, so increased risk of colonic polyps is seen in acromegaly. Second is carpal tunnel syndrome can occur in because of overgrowth of tissues. There will be compression of the nerves, and that is one of the early signs. Also there can be hyperprolactinemia. That this shock effect I had already explained in my pathology video, so please go back and watch that. I had talked in detail regarding the shock effect. So remember, GH growth hormone itself is not used for screening, IGF-1 is used for screening, and this is a very important repeated question which you will make mistake. Next is along with growth hormone deficiency, you will also get diabetes. Growth hormone excess will get diabetes. That is because growth hormone has a property to increase glucose levels. Okay, so it is hyperglycemic hormone. Third is assuming there won't be a normal glucose tolerance test, because glucose tolerance test will be deranged since growth hormone increases glucose levels in the blood. So oral glucose tolerance test with the growth hormone non-suppression is confirmatory for acromegaly. First test, screening test is IGF-1, and treatment is surgery in case of pituitary adenoma. If IGF-1 is increased, evaluate using GH suppression. If macroadenoma of pituitary is suspected, an MRI will confirm the diagnosis. If for pharmacological management, you use pegvosomant and you use octreotide. Okay, so monitoring glucose tolerance test and post of IGF-1 determines success rate of whether like surgery, that is transsphenoidal resection, has happened properly or not. And controlling sleep apnea is also very important in this case. The sleep apnea is again happening because of soft tissue overgrowth. So I have explained everything. We'll go on to the next topic, that is Addison's disease, coming to adrenal glands. So in Addison's disease, there is primary adrenal failure. Okay, that is adrenal insufficiency. Now this adrenal is because of adrenalitis or autoimmune adenitis, some reason, or maybe because of infection. This is basically failure of this adrenal secretion, adrenal function, as a result of which there will be decreased cortisol and decreased aldosterone. Decreased cortisol will cause fatigue, weight loss, and decreased aldosterone will lead to hyperpigmentation, because when aldosterone is decreased, mineralocorticoids are decreased, there will be feedback mechanism which will increase and stimulate production of ACTH. And surprisingly, this ACTH is closely related to MSH also, that is melanocyte stimulating hormone. So melanocyte will also increase stimulating hormone, that will increase melanocyte pigment production, and hence we get hyperpigmentation. All these things I had again discussed in pathology. So what are the common causes? Common causes, yes, it is autoimmune adrenalitis, which is the most common. And what is the classic triad that you get in exam? Fatigue, weight loss, and hyperpigmentation. Remember this: fatigue, weight loss, hyperpigmentation. So which are the electrolyte disturbances associated with Addison's disease, that is adrenal failure? One is hyponatremia, because the kidney's ability to retain sodium is lost, because aldosterone is the main hormone associated with the sodium retention, and potassium is increased. It will cause hyperkalemia. Next, cortisol will be low, SIADH will be high. Okay. What is adrenal crisis? Adrenal crisis means suddenly there is decreased production of this aldosterone and cortisol. As a result of it, suddenly body will go into circulatory shock and failure. So here you'll get hypotension, shock, and hydrocort will actually save life in that case. If mineralocorticoid action is needed, then we give fludrocortisone. Remember, corticosteroids are different and mineralocorticoids are different. If you want mineralocorticoid treatment, then you give fludrocortisone. If you want corticosteroid treatment, then you give hydrocortisone. Okay, both have some interchangeable properties. Like there will be some mineralocorticoid action also, but predominantly it is the way I said just now. So in case of surgery, like these are the reasons. Like if the patient undergoes surgery or any stress, in such cases this adrenal crisis gets precipitated. Okay, so these are precipitating factors: surgery, stress, and infection. So some rare facts are there is one syndromic association, that is autoimmune polyglandular syndrome, okay, APS syndrome, autoimmune polyglandular syndrome, which is associated with adrenal failure. Second, adrenal calcifications are seen in TB, and you'll also you'll see adrenal calcifications in TB. Okay. Now next is very important clue in your exam is this hyperkalemia, because hyperkalemia you will see in many cases, but hyperkalemia you don't see in many cases. Okay. So in endocrine cases, hyperkalemia is occurring. Always think of adrenal related issue. Confusing primary versus secondary adrenal dysfunction. So there are some primary causes, secondary causes. You should know that. I think we don't have to go to that depth. So remember, hyperpigmentation is there. It is primary Addison's. Adrenal crisis is that give IV hydrocortisone. ACTH is high along with low cortisol. It is useful for diagnosis. Increased potassium with decreased sodium is related to aldosterone deficiency. If no hyperpigmentation, consider secondary causes. Yes. So what this means was, primary means there will be hyperpigmentation. In secondary causes there won't be hyperpigmentation. Just remember this much. Okay. Next, you should increase the dose of this corticosteroids during stress. That is because during stress more cortisol is required, otherwise the patient can go into adrenal crisis. How will you titrate fludrocortisone dose? It is based on renin levels. Okay, so renin, which of the following is the levels for against which fludrocortisone is titrated, will be your question, and answer is renin. Okay, and these are hyperpigmented palmar creases seen in Addison's, and you'll see adrenal atrophy in this CT image here, adrenal atrophy. Okay. So I think I have answered almost everything. We'll go on to the next part, that is adrenal gland disorders overview. Okay, I think this slide should have come before this. No issues. So we have basically three parts of adrenal gland. One is outer part, that is zona glomerulosa, then zona fasciculata, inner part, and the innermost is zona reticularis. So this is the cortex part. Okay, then there is a medulla inside. This medulla is different. Medulla actually secretes this adrenaline and noradrenaline. Noradrenaline is mainly related to nerves, nerve endings, but adrenaline is from this medulla. So you have three zones here: GFR, that is glomerulosa, fasciculata, and reticularis. Outside glomerulosa secretes aldosterone, middle zone fasciculata secretes cortisol, and innermost zone reticulata secretes androgens. So control is via ACTH. So when these hormones decrease, ACTH will increase as a feedback mechanism. Okay. So I think I have we have gone through everything. Yes. Now coming to Addison's disease. Addison's disease is what? Primary insufficiency. That is all these levels are decreased. Cushing's is excess of corticosteroids is cortisol is Cushing's. Now what is Cons? Cons syndrome is increased aldosterone. So decreased aldosterone is Addison's. Increased aldosterone is Cons. So in Cons, symptoms will be opposite to that of to that of Addison's. Just now we saw Addison's had actually hyperkalemia. So here there will be hypokalemia. There we had shock and hypotension. Here we have hypertension. Okay. Similarly, Pheochromocytoma, where there is increased adrenaline secretion, epinephrine or norepinephrine. It's a catecholamine secreting tumor. Here we'll get triad. That is, triad is palpitation, sweating, and headache. So this triad of palpitation, headache, sweating because of excess catecholamines, that is known as Pheochromocytoma. Okay, we'll go into depth in the coming slides. So there is something called as adrenal crisis, which we now decrease. So sudden drop in hormones, the patient will go into shock. There will be hypotension and shock features. So you give hydrocortisone. IV hydrocortisone is a drug of choice. Similarly, there will be some deficiency, that is congenital adrenal hyperplasia. So because of a genetic defect, there will be decreased some hormone formation. Sometimes some hormones will be increased. So this will be discussing in detail in pediatrics. Okay. So there are some other causes of adrenal gland failure. That is, one is adrenal hemorrhage. Okay, adrenal hemorrhage can occur leading to acute adrenal insufficiency. This 17-hydroxyprogesterone, it is actually used as a first line test for detecting congenital adrenal hyperplasia. So what happens in congenital adrenal hyperplasia is there will be some defect in the enzymes. So there is big enzyme chart. Okay, so in this I'll be coming to that also. So in that we'll have certain enzyme deficiencies, as a result of which ACTH will be increased and it will stimulate overgrowth of adrenal glands. So there will be adrenal hyperplasia, but there will be deficiency of some hormones, and in one of the first hormone that we test is the levels of this 17-hydroxyprogesterone. Okay, so 17-hydroxyprogesterone is the most common hormone that we test. Next, pheochromocytoma arises from this chromaffin cell. This adrenal medullary cell, then known as chromaffin cells, from the pheochromocytoma arises. Now let's see this. Conn syndrome is what? Conn syndrome is adrenal gland that is excess of aldosterone. Okay, so in excess aldosterone, what will happen? There will be hypokalemia, so there won't be hyperkalemia. Next, second is secondary Addison's disease. If it occurs, there won't be hyperpigmentation. So you can see this emoji with the hyperpigmentation. So this is actually primary adrenal Addison's disease. Okay, and next is metyrapone is a drug which we use in Cushing's disease. Just remember that ketoconazole we use metyrapone. So all those we will use. We'll come to that one by one. So 21 hydroxyl is deficiency. So I told you 17 hydroxyprogesterone is the investigation of choice, first investigation in case of congenital adrenal hyperplasia. But the most common type, which there are many types of congenital adrenal hyperplasia, and the most common type is deficiency of 21 hydroxylase enzyme. Okay, and how to test this 21 hydroxylase enzyme? We do the investigation, we see levels of 17 hydroxyprogesterone. Okay, so if there is hypertension along with hypokalemia, yes, very good, it is Conn's disease. Episodic sweating, palpitation along with headaches, pheochromocytoma. If low cortisol along with high ACTH, yes, it is primary Addison's disease. If there is catecholamine tumor, we'll do MRI of abdomen first. Okay, we'll see whether adrenal gland hyperplasia is there or not. Next, if resistant hypertension is there, test for aldosterone also. So next thing is, you shouldn't abruptly stop steroids, because abruptly stopping steroids will precipitate acute adrenal crisis, and it is a life-threatening situation. Next is measure renin aldosterone ratio for Conn's. That is because in Conn's disease, what will happen is aldosterone will increase, okay, and renin will also increase. So this actually tells you whether there is increase in aldosterone or decrease in aldosterone. And last is regarding pheochromocytoma. Before adrenal gland surgery, you should rule out pheochromocytoma. Okay. So I think yeah, these things Addison's I have discussed. This Cushing will come to in a moment, and these are the 5 P's of pheochromocytoma. So next we'll go to Cushing syndrome. So what is Cushing syndrome? Excess of cortisol. Okay, so what are the features? So excess cortisol, it can be either endogenous means adrenal gland is producing, or it can be exogenous. Exogenous means we are giving from outside, that is like hydrocortisone or maybe prednisolone, whatever medication that we are giving. Because of that, Cushing's can occur. Now chronic cortisol excess will give rise to Cushing's phases. Okay, this is Cushing's phases. Central obesity will be there. There will be moon phase, there will be striae, there will be hypertension. So these are the features of Cushing syndrome. You shouldn't miss Cushing syndrome in your MCQ. So what is the screening test and what are the confirmatory tests? Screening test is overnight dexamethasone suppression test. So what is dexamethasone? Dexamethasone is again a steroid. Okay, it is a corticosteroid. So now when you give exogenous steroid, that is dexamethasone, what will happen is it will suppress cortisol. Okay, because you are giving from outside. But if cortisol is not suppressed even after overnight dexamethasone, then that means that there is some problem with the cortisol. That is, there is increased production of cortisol. So that is a screening test. Next is one more screening test is late night salivary cortisol, which is new test which you should know. And one more confirmatory test, we use 24-hour urinary free cortisol level. So what is the confirmatory test? 24-hour free urinary cortisol levels. And what are the screening test? Overnight dexamethasone suppression test and late night salivary cortisol screening test. Now why do we do this overnight? Why this night time? Because cortisol levels are maximum at morning. Okay, early morning cortisol levels increase. This is also the reason why we give steroids dosing early in the morning, because to mimic physiological dosing. So steroid will be highest in the morning. As the day progresses towards night, it will come down. Sorry, it will come down and then at night it will be minimum. So if there is any excess dose, excess levels at this point at night, that means it is some either some tumor or some exogenous or something is there which is causing increased peak at night. So it is not physiological. So there is some pathological aspect. So ACTH levels will be high in case of will be low in case of it can be high or it can be low. Based on that, we'll have two types. Okay, that is, if ACTH is high, what will happen? See, this is the pituitary gland. It will produce ACTH. Okay. I'll just change. Okay, so this is the pituitary, it will produce ACTH. ACTH acts on this adrenal glands, it will produce cortisol. Okay, so if cortisol we know is high in Cushing's, this is high, correct? So if ACTH is also high, that means this increased ACTH is from the pituitary is causing this adrenal to produce more cortisol. That's why it is high. So this means the cause is not here, the cause is somewhere in the CNS, in the pituitary. So it's a pituitary adenoma causing Cushing's syndrome, and this is known as Cushing's disease. Okay, this is known as Cushing's disease. Cushing syndrome is this one. Okay, Cushing syndrome is excess cortisol. But when excess cortisol happens because of increased pituitary secretion of ACTH, that is known as Cushing's disease. Now, in other case, what will happen is there is, let's say, a tumor of the adrenal gland. Now, what will happen? Cortisol is increased because of adrenal gland tumor or maybe some other reasons. Okay, related to the adrenal gland, or maybe we are providing it from outside like exogenous steroids. Okay, so now what happens? There is increased cortisol. Now it will suppress ACTH. So ACTH will be low. If cortisol is high and ACTH is low, that means the cause is in the either it is exogenous or it is in the adrenal gland. Okay, This is peripheral. Okay. If it is central cause, then what happens? Cortisol is high and ACTH is also high. In fact, high ACTH is causing increased cortisol. Now you will ask me, if ACTH is high and cortisol is also high, then why doesn't this increased cortisol inhibit ACTH? That is the pathology, because ACTH is secreted by a pituitary adenoma, and this adenoma is not getting suppressed by this high cortisol. So that is the pathology behind it. Okay. So hope there shouldn't be any confusion regarding this. So next is what are the complications? So most common complication is osteoporosis, infections, diabetes, that can be gastritis. There's n number of a big list of complications. Okay, so most common you should remember is infections. Okay, whenever there is infection, you don't give corticosteroids. Next is surgery is a definitive treatment. What are the other treatment? Ketoconazole and metyrapone. This is medical control. Okay. Yes, so central obesity, urinary free cortisol, striae, hypertension, hydrogen, neoplasm, glucose intolerance. I have discussed everything. So now, when there is ectopic ACTH secretion, no, they where does ectopic ACTH? What is ectopic ACTH? So ectopic ACTH is not exogenous ACTH. Exogenous ACTH is different. That is whatever the medications we are giving. Ectopic ACTH means we are giving some. There is some tumor like carcinoma of the lung which actually secretes ACTH. And this ACTH increases cortisol, that leads to Cushing's. Okay, so in ectopic ACTH we'll see severe hypoglycemia, because otherwise also there will be hypoglycemia and Cushing's, because there will be some aldosterone like activity and it will cause increased potassium excretion, so that will be there. But in ectopic ACTH level of hypoglycemia will be severe. Second is there is something called a pseudo Cushing's, where there is no excess cortisol but still there is moon phases and all those things that occurs in alcoholism and depression. And next is the CRH. CRH is corticotropin releasing hormone. It differentiates pituitary versus ectopic cause. Now I told you in this ACTH can be increased in case of adenoma, but it can also be increased in case of ectopic. Means I told there is some tumor which is secreting ACTH. Now how to know whether the increased ACTH is from the pituitary adenoma or whether it is from the lung which is secreting ACTH, lung carcinoma. So how to differentiate? Easiest method is this pituitary adenoma, no, whenever it secretes ACTH, this ACTH will inhibit something from the hypothalamus, because we know that hypothalamus, this is the whole axis, hypothalamus, pituitary, axis. Okay, hypothalamus pituitary axis. So here what happens? Hypothalamus will release corticotropin releasing hormone, that will act on pituitary releasing ACTH, that will act on adrenal releasing cortisol. Okay, so this is the complete mechanism. Cortisol inhibits ACTH and ACTH will inhibit CRH, that is corticotropin releasing hormone. Now if the tumor that is pituitary adenoma is causing increased ACTH, now what will happen? This will decrease the levels of corticotropin releasing hormone. So decreased levels of corticotropin releasing hormone means that there is the cause for the central Cushing's disease, central cause is actually from the pituitary. But what if corticotropin release hormones levels are normal? Okay, so let's say this is normal. Okay, then in that case ACTH is not coming from pituitary, it is coming from somewhere else, that is ectopic Cushing's. Okay, I hope you have got this. Next, yes, see here, next, yeah, where were we? Yes, CRH is used to differentiate pituitary cause versus ectopic cause. Now, treat osteoporosis and diabetes aggressively in case of Cushing's, because they can cause morbidity, and use steroidogenesis blockers, that is metyrapone, ketoconazole, if tumor is inoperable. Okay, and screen for infections before starting steroids. Next, using cortisol alone is of no use. Okay, next, you shouldn't miss exogenous, that is exogenous steroids. Exogenous means the medication that we give, that is the most important cause, and all ACTH secreting tumors, ACTH high are not pituitary. There are some ectopic ACTH causing tumors also. Next, if ACTH is low, adrenal source. If ACTH is high along with severe potassium loss, it is ectopic, related to lung carcinoma. If pituitary MRI is normal, then there can be a possibility it can be a microadenoma which is not visible on MRI. Okay, so I've explained everything. Yes, so this is pituitary, this is adrenal adenoma which you are seeing here. Okay, yes, I have discussed everything. Next, we'll go to diabetes insipidus. Okay, next we are going ahead with diabetes insipidus. So diabetes insipidus, and one more is SIADH. So these are at the opposite extremes. In SIADH, we have increased secretion of ADH. Okay, ADH secretion is increased, and in diabetes insipidus, we have failure of ADH secretion. So in diabetes insipidus, basically the hormone is ADH. ADH is antidiuresis. Means this is the output from kidney. Diuresis means urine is going out, that is increased urine formation and increased water excretion. So antidiuresis means this is preserved. So in SIADH, urine volume will be decreased. Okay, there will be decreased excretion of water. Okay, but in diabetes insipidus, this ADH is not there, and hence there will be excessive urine, excessive dilute urine. Okay, so basically you should know that the diabetes insipidus, it is a problem of water metabolism in the body. Okay, it is not regarding how much urine is formed. It is basically about dilution of urine. So there can be two causes. One is ADH. Where is it produced? It is produced from the posterior pituitary. So posterior pituitary has two hormones. One is vasopressin, and second, which is known as ADH, and second is oxytocin. Okay. So this vasopressin or ADH secretion from posterior pituitary can be hampered, leading to central diabetes insipidus. And second is this ADH will go and act on the receptor, okay, that is present in the kidneys. These are known as V1, V2 receptors, okay. So there can be problem with these receptors in renal diseases or when associated with some hypercalcemia, when associated with lithium. Actually, lithium induced nephrogenic diabetes insipidus we have discussed in detail in pharmacology. So these are the two types of diabetes insipidus. So what is the hallmark? Large volume of urine along with low specific gravity, which means it is diluted large amount of urine. And what happens to serum sodium levels? Because water is all excreted in the urine, but sodium is not excreted. So in body, sodium concentration will increase because fluid status of the body will go into dehydration type because everything is excreted in the urine and sodium is not excreted, hence sodium levels will rise. Now, there are some diagnostic tests. One is known as water deprivation test. So basically, there are three types of diabetes insipidus. One is central diabetes insipidus, nephrogenic diabetes insipidus, and third is psychogenic diabetes insipidus. Psychogenic means patient drinks more water and hence he has more urine formation. Okay, so that is known as psychogenic. Now, how to know, how to differentiate whether it is psychogenic or not is you stop giving water to patient. That is known as water deprivation test. If after water deprivation test, you check the sodium levels and you check urine volume, okay, and it is found to be normal only, there is no change, then it is because of psychogenic. Means patient is drinking more water, that's why he has diabetes insipidus, that is more, that is polyuria, okay, that is the reason for polyuria. Now, to differentiate between central diabetes and nephrogenic, what you do is, in nephrogenic, I said you that there is ADH resistance at the level of the receptors. In central, there is decreased ADH. So what to do? You give an analog of ADH. ADH analog is nothing but vasopressin. Vasopressin is the other name for ADH, and analog of vasopressin is desmopressin. So you give intranasal or IM desmopressin. Now this desmopressin will act like ADH. What will happen in case of central diabetes insipidus? Since ADH will be low, this desmopressin will go and sit on the receptor and it will decrease diuresis. Decrease diuresis. Correct. It will cause antidiuretic effect and hence polyuria will decrease. So, but what happens in nephrogenic? In nephrogenic, there won't be any effect because if you give desmopressin or if you give vasopressin, whatever, still there will be ADH resistance. So there won't be any action at all. Okay. So this is how you differentiate psychogenic versus nephrogenic versus desmopressin. Okay. So this is known as desmopressin test. Water deprivation test is used for psychogenic diabetes insipidus. Desmopressin test is used to differentiate central and nephrogenic diabetes insipidus. So what is the treatment I told you? If it is central, just supplement it with ADH or vasopressin. The analog is desmopressin. If it is nephrogenic, then you have to do some other therapy. So here you give actually thiazides. One is thiazides. Okay, and second what you give is NSAIDs, which is indomethacin. Okay, these are known to improve. One more is amiloride, which is used specifically, this is a discussion pharmacology also. Amiloride is used in lithium-induced nephrogenic diabetes insipidus. Amiloride. So what is one complication? It is severe dehydration because every fluid is lost in the urine, okay, in diabetes insipidus. Now, some rare facts. What is gestational diabetes insipidus? See, during pregnancy, there is an enzyme which is released, which is known as vasopressin, which breaks down ADH. As a result, ADH action will decrease. So, gestational diabetes insipidus is one condition which you should know about. Second is lithium toxicity. It causes nephrogenic diabetes insipidus, and nephrogenic diabetes insipidus, we give amiloride. Remember this, okay? Next, in hypercalcemia, there will be decreased response of aquaporin channels, okay, which are channels which are inserted in the epithelial cells of the kidney, tubular cells of the kidney, because of ADH. So this is decreased, and hence we'll get diabetes insipidus in case of hypercalcemia. Okay, all these things I have told you. So I think there is nothing else I have told you. Yes, monitor serum sodium closely, stop lithium possible, and hydration is essential. Okay, next we'll go to diabetes mellitus. Type 1 and type 2 will have diabetes on multiple occasions in coming slides also. So what is the problem with diabetes? This is diabetes pancreatic beta cells of endocrine pancreas. In type 1 there is autoimmune destruction of these beta cells. Okay, so insulin is not produced and it will lead to hypoglycemia. And here in type 2 we have insulin resistance, insulin receptors resistance is there, and hence even though insulin is higher, but still beta cell needs to produce more insulin, and there will be pressure on this, and ultimately it will undergo failure and it will lead to hyperglycemia. So what are the symptoms? Polyuria, polydipsia, and weight loss and polyphagia also. I think I have already told this. HbA1c more than 6.5 or fasting blood glucose more than 126 or postprandial more than 200. Okay, more than 200. Okay. So these three are criteria. Now, what are the long-term complications? Neuropathy, nephropathy, retinopathy, MI, stroke, all this peripheral vascular disease, everything I have told you. Now, insulin is mandatory in type 1. In type 2, we give metformin as the first choice, and we'll give some sulfonylurea or some insulin-secreting therapy. So, in emergencies, what is that? One is DKA, and in type 2, we have hyperosmolar hypoglycemic syndrome. Okay, so HHS, which has higher mortality. Now, what rare facts are LADA. What is LADA? Late onset diabetes of LADA is slow onset autoimmune type 1 diabetes. So, LADA is latent autoimmune diabetes in adults. Okay, so which means type 1 diabetes which occurs in adults is known as LADOC. It is slow onset, and later on they will go for insulin dependence. Okay. Next is gestational diabetes mellitus, which we'll be discussing in OBG, and SGLT2 inhibitors, which we had already seen in pharmacology. They actually reduce cardiovascular mortality. Okay. So I have discussed all of this. Yes, I have discussed this. Obesity and acanthosis are seen in type 2 and not in type 1. Okay, you have to do annual retinal scan, microalbumin screening to see for nephropathy. ACE inhibitors are used that protect the kidney. Then SGLT2 inhibitors are useful in heart failure. We have already discussed this in pharmacology. Yes. So next we'll go to next topic, that is diabetic ketoacidosis. DK is one topic which, even though you don't have a strong MCQ skill to solve this, but you should have clinical base to solve this, because I have seen children with severe decay improving a lot. Like if you manage decay properly in the first 24 hours, then you'll see wonders. Like within 24 hours, 48 hours, the child will be totally sitting and having food. Okay, so decay is one such beautiful disease where you can treat. There are complications. It is very complicated to manage also, but still it is one disease where you get the return in for whatever investment you have done. Okay, your time invested on the child or adult patient. Yes. So in decay, what happens? There is absolute insulin deficiency. There is no insulin at all, and then body will depend on ketone production. So there is lipolysis. So there will be metabolic acidosis also, because ketone bodies are produced, and that will lead to severe dehydration overall because of hyperglycemia. Okay, so there are some common triggers: infection and missed insulin and all. So there is lipolysis, and the question will be which is a predominant ketone body, and the answer is beta hydroxybutyrate. So there are three types of ketone bodies: one is acetone, one is acetoacetate, and one more is beta hydroxybutyrate, and beta hydroxybutyrate is the most important ketone body. So what is the hallmark? Hallmark is high anionic gap metabolic acidosis, that is HEGMA. Okay, and this increased anion is because of this ketones. Okay. Next, blood sugar will be in the level of 250 to 600. Now you will have to differentiate DKA from HHS. In HHS, sugars will be more than 600. In DKA, it will be around 250 to 600. And total body potassium is decreased in case of DKA. That's why when we start treatment of DKA, first we'll see what is the potassium levels. When we start insulin, what will happen? Potassium will go into the cells, and it can cause severe hypokalemia. So that's why it will cause more severe hypokalemia. That's why we always see for potassium levels, and we add potassium only if necessary. Okay, initially only we won't add. We'll first see for potassium levels. So first, when we do ABJ, what we are saying is, see, DK is diabetic, keto. We talked about diabetic, we talked about keto. Now we are talking about acidosis. Now based on this acidosis, we have criteria, that is pH, then pH and bicarbonate. Okay, so if pH is less than 7.3, okay, 7.3 we'll take it as cutoff. If it is 7.3 to 7.2, then it is a mild DKA. Okay, along with bicarbonate of 15, this is the cutoff. This is for mild. I'll take a pen only. Yes. So for DKA, mild DKA, moderate DKA, and severe DKA. Okay. For mild, we take pH 7.3. Here it is 7.2. Here it is less than 7.1, and bicarbonate is 15, 10, 5. So these are the bicarbonate value and pH value to categorize DKA. So based on that, we'll be managing. If it is severe DKA, we will directly follow management protocol. That is IV fluids. We'll give IV rehydration first without any electrolytes and without insulin. We don't start insulin straightforward. We first give IV fluids only in the first 1 hour. Okay, IV fluids only in the first 1 hour. Then we start insulin. And which insulin we start? We start regular insulin. Okay. So potassium replacement is done once we see the potassium values, and after 1 hour, when we start insulin, that time we'll give potassium replacement. So serum ketones can be falsely low also in some cases, so we shouldn't exclude. Criteria for DK is, there are 3 criteria. One is RBS is 250 to 600, that is more than 250. Okay, that is one. Second is pH is less than 7.3, and third is urine ketone bodies are positive. Okay, urine ketone, it is either 2 plus or urine strip, or it is more than 3 millimole, some value is there. Okay, so this is the definition of DKA. So don't just rely on ketone bodies. Sometimes ketone bodies can be falsely low also, because initially ketone bodies will be low, and later on ketone bodies will start to increase. So cerebral edema risk is that this is the only dreaded complication under DKA, management of cerebral edema. SGLT2 inhibitors can sometimes act as a trigger in case of DKA. Okay, next, before starting insulin, always see potassium and do potassium correction, because once you give insulin, then potassium will go inside the cell, and it will worsen hypokalemia if it is already present. Next, using sodium bicarbonate routinely has no role. Remember, what will happen is you will think that here bicarbonate is less, so you can use sodium bicarbonate. I'll tell you from my experience during residency. Once someone had seen that there was severe decay, but they didn't measure RBS. So this was like a very big mistake. RBS was not measured. The person whoever was on duty just saw that there was some diarrhea along with pain abdomen. He thought it was because of acute diarrheal disease, and when he saw bicarbonate levels, pH was less than 7.1, bicarbonate was 5. So as an instinct, what he did directly, he went and used sodium bicarbonate, and the child landed in cerebral edema. Okay, so it is one of the most dreaded complications. We never use sodium bicarbonate in DKA. Next, insulin will be continued till anion gap will close. What is the meaning of anion gap will close? This pH will start to increase. Okay, so till then we'll be giving insulin, and then we'll be converting from IV insulin to regular insulin. So high anion gap with ketones suggestive of DKA. Beta hydroxybutyrate is the most important. Fluid resuscitation is first. Insulin is not first. Okay, insulin we start 1 hour after IV fluids. If infection signs are there, then that is precipitating factor. If potassium is low, first correct potassium, then give insulin. If mental status worsens, it is suggestive of cerebral edema. Okay, so monitor glucose closely, avoid rapid osmolality correction, and continue basal insulin after stabilization. That is, you start subcutaneous insulin. Okay. So I think I have explained everything. Yes, one thing is what is anion gap. Anion gap is means there are some positive ions and there are some negative ions. Okay, these positive ions are basically, I'll just take pen. Yes, these positive ions are basically sodium in the extracellular fluid. Okay, calcium is there, and so there's mainly sodium. Okay, so if you ask me which is the main positive ion, it is sodium. So to balance this, there are some negative ions, anions, and anions mainly are chloride and bicarbonate. But the problem is this sodium is not equal to this chloride and bicarbonate, because there are some like anions which are not present directly, which are not measurable. This is known as anion gap. Okay, so this anion gap is there. No? This is normally 8 to 12. Now what happens? Suppose there is increase in positive charge because of some extra H plus ions. So let's say ketone bodies, or let's say salicylates, or let's say methanol leads to formic acid. Okay, so this formic acid. Okay, or in case of any other, okay, polyethanols. Okay, they can also cause, or it can be in case of metabolic diseases, like metabolic diseases means metabolic congenital diseases, like let's say in case of maple syrup urine disease. Okay, we have increased acid generation. Okay, so in all these cases H plus ions are more. Okay, as a result of which we want more of negative charges also. So in this case this anion gap actually increases. So in case of diabetes we have extra ketones. Now these ketones will require extra anion gap, right? That is the importance of anion gap in diabetic ketoacidosis. Okay, next, fluid resuscitation is most important. Yes, I think I have covered everything. Yes, okay, we'll go on to the next topic, that is gestational diabetes mellitus. So what happens is, the reason behind gestational diabetes mellitus is there will be placental hormones which are secreted by the placenta. These placental hormones will be acting on these insulin receptors, which will increase insulin resistance and in turn cause hyperglycemia. Okay, this is usually found in the second trimester, that is between 24 to 28 weeks, when we do oral glucose tolerance test, which will be screening test of choice. And gestational diabetes mellitus will have fetal risk including macrosomia and shoulder dystocia. Okay, so it is done between 24 to 28 weeks. First prenatal visit, in first prenatal visit, very high risk screening will be done, and Carpenter-Koshner criteria or IIT PhD criteria is used. We'll discuss this in OBG in detail. So obesity, PCOS, and family history of gestational diabetes, diabetes mellitus is risk factor. Predisposing factors are preeclampsia and polyhydramnios. So what will be the fetal complications? One is respiratory distress syndrome. Second is shoulder dystocia, hypoglycemia, and macrosomia. Now you will ask me, how will hypoglycemia occurs? It is same. It is because of hyperglycemia, which in turn leads to rebound hypoglycemia. Okay, prolonged hypoglycemia. Next, diet plus exercise is the first line. So never tell medications. Diet and exercise is the first line, and then insulin is preferred. Insulin is the drug of choice. Other facts are metformin is used if insulin, the patient is refusing insulin, then we go for metformin. Okay, it will increase future risk of type 2 diabetes mellitus, actually gestational diabetes mellitus. Okay, and next is macrosomia will be there, even though there will be weight control, but still macrosomia is unavoidable because that is because of insulin growth factors. Okay, insulin like growth factor, which is causing fetal overgrowth. It is not because of weight control or any other things during pregnancy. Okay, next, I think I have explained all this. This one also I have explained. Yes, if macrosomia is there in pregnancy, then suspect GDM. If poor diet control, then start insulin. If postpartum hyperglycemia persists, then you have to think for type 2 diabetes mellitus. Okay. Now breastfeeding reduces maternal risk. Fetal growth monitoring you have to do closely, and repeat OGTT, that is oral glucose tolerance test, 6 to 12 weeks after delivery. Okay. So you are seeing macrosomia over here, and this is OGTT test. Okay, so this is regarding GDM, a very short issue because we are anyways going into depth in OBJ. Next we are coming to thyroid, that is Graves' disease. Moving on to hyperthyroidism, in this we have first Graves' disease. Okay, so what happens in Graves' disease? There are antibodies against this TSH receptors. Okay, so that will lead to increased T3, T4 production and its release, causing hyperactive thyroid gland also, and as a result of which we'll have hyperthyroid features. So it's basically autoimmune mediated disease, autoimmune TSH receptor stimulation causing diffuse hyperthyroidism. So you can understand, right? Because this is TSH antibody, that's why there will be enlargement of the thyroid gland. Okay, it will sit on these thyroid cells and it will cause hyperactive thyroid gland along with enlargement. So since it is autoimmune, it is more common in women. What are the symptoms? Heat intolerance, weight loss, tremors. Then eye signs are there. You should know all the eye signs, which will be covering in ophthalmology. Exophthalmos, lid lag, all are there. Then there will be diffuse goiter and there will be audible bruit when you hear over thyroid gland. Investigation wise, TSH will be low. TSH will be low, okay, because you have increased T3, T4. In hyperthyroidism, TSH will be low. T3, T4 will be high, and you will get TSH receptor antibody. Okay, so antibody will be positive. Imaging, you will see that on radionuclide imaging, iodine scan, you will see diffuse high uptake on the scan, which means thyroid gland is very active. And drug of choice is carbimazole and propylthiouracil. We had discussed this in detail in pharmacology endocrine. Okay, and definitive is radioiodine or surgery, that is radio ablation of thyroid gland or surgery. Okay, now what are some extra things that you should know? Pretibial myxedema, even though it is mainly seen in hypothyroidism, but it can be seen in some cases of hyperthyroidism also. Second, smoking worsens ophthalmopathy, ophthalmic symptom that is worsened in smoking. Okay, next, radioactive iodine is not used in case of pregnancy because it is teratogenic. Next, thyroid storm is one important question which will be going in the next slide, what thyroid storm is. And this goiter shouldn't be confused with multinodular goiter. Here it is hyperthyroid. In multinodular goiter also there can be features of hyperthyroidism. So multinodular goiter is different from Graves' disease. Okay, yes, I have discussed all this. If severe symptoms are there, like tremors and all, hypertension, tachycardia, then we give beta blockers to control those symptoms. Ophthalmopathy will worsen post radio ablation therapy, iodine, so you have to give steroids. So this is one case scenario that might come, like a patient with Graves' disease underwent radioactive iodine therapy, and after that patient was found to have worsening ophthalmopathy. So which of the following is the management? Then answer is steroids. Okay, so monitor antithyroid, monitor ANC, that is. So we'll have to monitor absolute neutrophil count during antithyroid therapy, because propylthiouracil is known to cause decreased neutrophil counts. Okay, next, Graves' disease, these are the mnemonics, just remember this. And PTU is the drug of choice for pregnancy, first trimester of pregnancy, and second and third trimester. In first trimester you don't use PTU. Okay. Next, we'll go through Myxedema coma, that is hypothyroidism. So what will happen is hypothyroidism will be so severe that there will be entire metabolic slowdown and patient will go into coma. I had seen one such case in my internship where a patient came and then her TSH levels was 102, like 102, it's very, very high. So then she came actually in coma, and then we diagnosed it as Myxedema coma. Like, she was a known case of hypothyroidism, was irregular on medications. Okay, so autoimmune Hashimoto's disease is the most common type, Hashimoto's. Then followed by surgery, post-surgery removal of thyroid can also cause this. Iodine deficiency is rampant in India. Other causes are for autoimmune Hashimoto's, we'll see anti-TPO positive antibodies. Okay, anti-TPO is what is done, thyroid peroxidase. So what are the symptoms? Symptoms are fatigue, weight gain, cold intolerance, hypothermia, bradycardia, altered sensorium in case of Myxedema coma. Okay, and what are the precipitates of Myxedema coma? One is infection. Infection, second is cold exposure, and the third is sedatives, which can act as trigger. So treatment for Myxedema coma is very simple. It is not oral thyroxine, it is IV thyroxine. Remember, IV thyroxine is very rare to get also. So the first line of treatment is IV thyroxine, and second, for supporting, we have IV hydrocortisone also, because these patients it can actually help in reviving these patients. Okay, reviving the metabolic state. Also, monitoring cardiac status is essential, because these patients can go into bradycardia and go into cardiac arrest also. So this is the mnemonic to remember this, like memory loss, obesity, all these things are related to hypothyroidism. Okay, and then you give this Myxedema management, which we will study now. One is IV thyroxine, which is basically IVT4 thyroxine. Next, temperature regulation, watch electrolytes, observation, infection control, saline. Then you give steroids, that is IV hydrocortisone also. You give respiratory support and you control infection, and then you give dextrose. Okay, so this is the management protocol. Now coming to other aspects, one is SIADH. So SIADH-like state is seen in hypothyroidism. The reason behind this is that because of Myxedema coma, there will be low cardiac output state, because there is bradycardia. Okay, so there is low cardiac output state, and because of this low cardiac output state, and even pumping capacity of the heart is also decreased. So because of that, there is circulatory load will decrease, okay, that circulatory blood volume will decrease, as a result of which circulatory blood volume will decrease, as a result of which there will be increased ADH secretion. We have seen in the last few slides that ADH secretion will increase when there is circulatory volume decreases, that time ADH will increase. So when ADH increases, what will happen? There will be hyponatremia. So in Myxedema coma, you will get ADH like picture, that is you can get hyponatremia. Next, there will be elevated CK because there is myopathy, damage to the enzymes, and there will be hypoventilation secondary to altered sensory Myxedema coma. Okay. Now, using oral T4 is not at all helpful. It should be IV levothyroxine, IV T4. Okay. Next, dealing steroids is also wrong because you have to give IV hydrocortisone, and missing hypothermia because hypothermia is also a component of Myxedema coma. So if TSH is high and T4 is low, it is primary hypothyroidism. Okay. IV T4 is used in Myxedema coma. Anti-TPO antibodies are seen in Hashimoto's thyroiditis. Next, coma along with hypothermia is Myxedema coma. TSH decrease along with T4 decrease is secondary hypoparathyroidism. Similarly, we had discussed the same thing for growth hormone also. Similarly, and for SIADH also, that is in Cushing's, Addison's disease also, and in Cushing's disease also. So if TSH is decreased, which means there is decreased TSH production from the pituitary, as a result there is decreased T4 production. Okay. Next, severe bradycardia, start treatment very cautiously under cardiac monitoring. So you have to warm gradually, not suddenly. Ventilator support you have to give and search for infection source. Okay. Now this is myxedematous facial swelling that you are seeing, and these are the low voltage ECG complexes that you see, and bradycardia also that you see in case of Myxedema coma. Okay. So once thyroxine is given, there will be gradual improvement. Okay. Next we are going for very important calcium and bone metabolism. We call it as mineral bone metabolism. Okay. So we'll cover many aspects here. Yeah. So hypercalcemia means elevated calcium levels. So we take the value as more than 10.4 mg per dl. Okay. So more than 10.4 means 10.5 and above is hypercalcemia. Okay. So it will cause what? Neuromuscular dysfunction. That is, it will cause psychological overtones. Okay, psychic overtones. It will also cause renal dysfunction, and it will cause cardiovascular dysfunction. So these three systems are affected. Okay. Now, what is the most common cause? Most common cause in the outpatient part is actually primary hyperparathyroidism. So some defect in primary in the parathyroid gland, which actually secretes more PTH, parathyroid hormone, which actually in turn increases calcium levels. Okay. We know that parathyroid hormone directly increases calcium levels. Second is malignancy, in which there is release of this parathyroid hormone related peptide, PTH RP, okay, parathyroid hormone related peptide, which actually is seen in bone metastasis tumors. Okay. Next, third is sarcoidosis, where there is increased production of 1-alpha hydroxylase. Now, if you remember biochemistry, we are going to discuss. Okay, we haven't discussed this. We will go to discuss that there is 1-alpha hydroxylase enzyme which is present in the kidney. Okay, so this will convert inactive vitamin D3 into active vitamin D3. So as a result of which there will be it's present in the kidneys, and it will convert this, and as a result of which vitamin D3 level will increase, which actually in turn increases calcium levels. Other drug causes are thiazides and lithium. Remember, furosemide, which we discussed this in pharmacology, furosemide actually and loop diuretics, they will cause decreased calcium. Okay, they will decrease calcium, whereas thiazides, they increase calcium. And fifth is immobilization causing increased bone resorption, which is a minor cause. Now, what are the symptoms? So the symptoms are groans, stones, bones, and psychic overtones, which means there will be abdominal pain because of hypercalcemia, there will be kidney stones, there will be bony pains, and there will be psychiatric overtones. So these system covers these three main organs. Okay, and along with this, there will be a component known as nephrogenic diabetes insipidus. If you go 2 slides back into diabetes insipidus, we saw that one of the causes hypercalcemia. So hypercalcemia is also causes nephrogenic diabetes insipidus, which in turn causes polyuria. Now, very important ECG clue is QT interval. Now, what is this QT interval and what is corrected QT interval? Because this is a star exam question. Okay, so see here, this is P wave, this is Q, this is R, this is S, and this is T. So beginning of the Q wave, okay, this is the Q, negative wave is Q wave, to the end of T wave is QT interval. But what will happen is, suppose let's say the patient has tachycardia. When the patient has tachycardia, this QT interval now automatically decreases. See here, it decreased. So based on tachycardia or bradycardia, we can't differentiate whether QT interval, it can't be used as a reference standard. That's why what we do, we use something known as QTC. QTC means corrected QT interval. So how do we do corrected QT interval? We just put QT interval, whatever we have obtained, divided by square root of RR interval. So this is known as Bazet's formula. Okay, this is very, very, very important. This is known as Bazet's formula. Next, there is something known as milk alkali syndrome, which means that whenever there is increased bicarbonate, that is an alkalosis, when there is absorption of more amount of alkali, that is bicarbonate, along with the increased calcium absorption, okay, increased bicarbonate, increased calcium absorption, because of increased calcium intake, it is also associated with one more feature, that is renal dysfunction. Okay, this three triad, alkalosis, hypercalcemia, and renal dysfunction, this is known as milk alkali syndrome, and this is one of the causes for hypercalcemia. Okay, next, when is hypercalcemia very critical? It is when calcium values go above 14. So vitamin D intoxication can also cause, because vitamin D intoxication exogenously, like you are giving some vitamin D capsules or medications, because of which calcium and phosphate both will increase. Now, what happens in primary hyperparathyroidism? PTH is high, calcium is also high. What happens in secondary hyperparathyroidism? So secondary hyperparathyroidism, what happens is, there is actually, in secondary hyperparathyroidism, there is actually low phosphate. Okay, phosphate is the strongest, low phosphate is the strongest stimulus for parathyroid hormone. And because of which, because of low phosphate, low parathyroid hormone, which is because of low phosphate, what will happen? Because of low phosphate, parathyroid gland is stimulated. This is parathyroid gland, it is stimulated. It will secrete increased parathyroid hormone, okay? And this increased parathyroid hormone causes hypercalcemia. This occurs in renal disease, okay? In renal disease, excretion of phosphate is affected. So there will be, the thing was that because in renal disease what happens, in renal disease what happens is, there won't be excretion of phosphate, okay? Phosphate won't be excreted, as a result of which phosphate will increase in blood, phosphate will chelate with calcium, okay? So phosphate, as a result of which calcium will decrease, and this decreased calcium along with increased phosphate causes increased PTH release, and this increased PTH is a cause for secondary hyperparathyroidism, okay? This occurs in renal diseases, okay? Sorry for the concept mismatching. Yeah. So what's the treatment for hypercalcemia? Just like DKA, where you had a lot of diuresis and all, and the patient was severely dehydrated in DKA. Similarly, in hypercalcemia also, patient will be severely dehydrated. That's when we start IV normal saline, okay? That is, we give hydration first. Then we give calcitonin and bisphosphonates. Calcitonin acts on this paramedullary cells, okay, P cells of the thyroid, and it will decrease the calcium levels, and bisphosphonates, they decrease bone resorption of calcium, okay. Next, you have to monitor renal function, because renal disease can also be associated with the hypercalcemia, okay. So I have explained everything. And second is, you have to screen for renal stones also. Kidney stones can also be seen. Next, milk alkali syndrome causes metabolic alkalosis. I have discussed this. Using furosemide before hydration, yes, this is wrong, because furosemide, you will think that if you use furosemide, you can actually excrete calcium, but we are more concerned about the volume status. Patient will already be dehydrated, and if you give furosemide, patient will go into shock, because furosemide will in turn cause increased diuresis. Then QT interval I have already told, and more than 14 is severe hypercalcemia. Okay, so I have discussed everything. If PTH is high, it is primary hyperparathyroidism. It can be secondary hyperparathyroidism. If calcium is high and PTH is high, it is primary, because parathyroid hormone is regulating calcium directly. If PTH is high and calcium is high and PTH is low, that means it is because of PTH-RP, that is parathyroid hormone related peptide, and that is seen in malignancy. If calcium is high and there is renal stone, that means it is hyperparathyroidism. Okay, that's why, because there is hypercalcemia and increased renal excretion also. So adequate hydration control is important, and treating underlying malignancy is also important to prevent hypercalcemia. I think I have discussed everything regarding this. Yes. So we'll go to next to hyperparathyroidism. Here we'll discuss everything in detail. Okay, including secondary hyperparathyroidism. So in primary, there are three types: primary, secondary, and tertiary. Okay, so primary is because of some tumor which is causing increased parathyroid hormone secretion, which in turn increases calcium, and it leads to hypercalcemia. In secondary, what happens is, in secondary, as I told just now, in renal disease, phosphate is not excreted. As a result, phosphate increases, phosphate will chelate calcium, as a result of which calcium decreases, there is hypocalcemia, and these in turn will stimulate parathyroid, because decreased phosphate will stimulate parathyroid gland, causing increased PTH, and there will be hyperparathyroidism, and this PTH increase will try to compensate calcium. Okay, so that's why in later part of the kidney disease only then we'll see hypocalcemia, but initially we'll have hypophosphatemia, but calcium will be normal. In later stages there will be decreased calcium also. Okay, so that is CKD causing hypocalcemia, and it causes secondary hyperparathyroidism. Now tertiary is when there is autonomous PTH after chronic secondary. This means that, so tertiary hyperparathyroidism means because of this secondary hyperparathyroidism chronically. Okay, so what happens is this parathyroid gland will lose the function to regulate calcium, and as a result, even though calcium is high, phosphate is high, PTH still remains high only. Okay, there is no regulation at all. Okay, so that is when there is autonomous PTH secretion after chronic standing secondary hyperparathyroidism. It is in post-renal failure. Now, along with this, we'll see complication, that is renal stones, because more calcium is found, more calcium is excreted, and this more calcium will get deposited in the urinary tract. What will be the biochemical test? What do they say? Calcium will be increased, phosphate will be increased, and parathyroid hormone will be increased, and phosphate will be decreased in case of primary hyperparathyroidism. That is because PTH, what does PTH do? PTH will increase calcium. It will cause calcium absorption, and it will cause phosphate excretion. Okay, that is the primary role of PTH. Whereas the role of vitamin D is to increase levels of both calcium and increase the phosphate. For PTH, it is increase calcium but decrease phosphate. Okay, so that is why we'll have decreased phosphate in case of primary hyperparathyroidism. What happens in secondary hyperparathyroidism? In secondary hyperparathyroidism, phosphate will be increased because kidney is not excreting it, so phosphate is increased. As a result of which, calcium will be decreased, and when there is increased phosphate and calcium is decreased, PTH will increase paradoxically. Okay, so this is for secondary hyperparathyroidism. So what happens in tertiary hyperparathyroidism is because of long-standing secondary hyperparathyroidism, there is increased autonomic secretion of PTH. Even though when calcium is low, but still low calcium will continuously cause increased PTH autonomous secretion. So we'll have increased calcium levels, but still there will be increased PTH levels. Okay, so this is in tertiary hyperparathyroidism. So what are the side effects or what are the complications? One is renal stones. Nephrocalcinosis is a complication. And second is it can cause peptic ulcer, and pancreatitis are known to happen with hypercalcemia. Okay. Next, bone changes can occur because of PTH action. There will be some periosteal resorption of the bone. On ECG, you will find short QT interval as opposed to long QT interval that we see in hypocalcemia. Treatment is parathyroidectomy, which is definitive treatment for primary hyperparathyroidism secondary to parathyroid adenoma or increased secretion of PTH. And second is during parathyroidectomy, we can, after post-parathyroidectomy, we can have something known as post-parathyroidectomy hypoparathyroidism. Okay, that also can be seen. So this is the basic pathophysiology: excess PTH secretion, increased calcium reabsorption, phosphate excretion, causing hypercalcemia and decreased phosphate, and then bone resorption is the main mechanism through which there is increased calcium. There is increased calcium in the blood. Okay. Next. This is in hyperparathyroidism, bone becomes something as brown tumor. Okay, so this is known as brown tumor. Primary hyperparathyroidism is also known as brown tumor of the bones because there is increased resorption of calcium from the bones. Okay. Next, lithium levels actually increases PTH levels. Just remember this, not a very useful fact. Cinacalcate is useful in tertiary hyperparathyroidism. Yeah, so how cinacalcate works, for that you should know what happens in tertiary parathyroidism. In tertiary, because of long-standing secondary, there is decreased secretion of vitamin D3 from the kidneys, as a result of which calcium will decrease. And this decreased calcium, which happens in secondary hyperparathyroidism, will ultimately cause parathyroid gland to lose sensation of, that is, the feedback of calcium, increased parathyroid hormone will be secreted. So that is lost, and parathyroid gland will have autonomous function. So it will secrete parathyroid hormone, so it will secrete in large quantities. As a result of which calcium will increase, there will be hypercalcemia, and phosphate will be increased because of underlying renal disease. Okay, so increased PTH, very high PTH, along with increased calcium, along with increased phosphate is seen in tertiary. So what is the difference in tertiary and secondary? In secondary, calcium levels will be normal or will be decreased. In tertiary, calcium levels will increase because of autonomy of parathyroid gland. Okay, releasing increased parathormone. Now, what does cinacalcate do? Is cinacalcate sensitizes a calcium sensing receptor. There is something known as CASR, that is calcium sensitizing receptor present in the parathyroid gland, and cinacalcate will increase in sensitizing this receptor to increased calcium levels, as a result of which PTH levels will decrease. So cinacalcate role is useful in tertiary. Okay, so don't confuse primary, secondary and tertiary hyperparathyroidism. Phosphate levels are important. Phosphate levels are raised both in secondary and tertiary. Okay, and ignoring CKD as a cause is very fatal because you will lose marks if you lose this option. Okay, so here you see in primary, PTH is increased mainly because of which calcium increases, phosphate decreases. In secondary, there is decreased calcium initially because of decreased vitamin D3 secretion by the kidney, as a result of which calcium decreases, as a result of which phosphate increases, and because of renal disease we have decreased phosphate also. Okay, PTH increases. Now in autonomous secretion, PTH is increased many times, calcium is also increased, and then we have decreased phosphate. Okay, so increased phosphate, that is because of renal disease. Okay, here also we have increased phosphate because of renal disease. Only in primary hyperparathyroidism we will have decreased phosphate. So if calcium is increased along with increased PTH, yes, that means PTH increase is causing increased calcium along with the decreased phosphate, that is seen in primary. Second is if PTH is increased along with decreased calcium and there is increased phosphate, that means it is kidney disease and it is secondary hyperparathyroidism. And long-standing secondary, if there is increased calcium and increased phosphate that was already there, that means it is tertiary. So the only difference between secondary and tertiary is the level of calcium. Okay, calcium will be increased in long-standing and here it will be decreased. Next. What are the other things? One is always when you treat hypercalcemia or hyperparathyroidism, always see vitamin D levels, because if vitamin D levels are less, automatically PTH is going to be high because decreased vitamin D3 levels will cause decreased calcium, and this decreased calcium will stimulate increased PTH. So you should be very careful. Second, you should manage CKD, bone mineral disease properly, because all these are combined. Renal disease is combined to vitamin D3. Vitamin D3 is linked to calcium levels. Calcium levels is related to PTH. PTH is related to phosphate, and phosphate excretion is related to directly CKD. So all these are intertangled. And hydration is important to prevent renal stones. Okay. So PTH excess causes calcium, increased calcium causes hypercalcemia, and you can see this increased PTH on adenoma scan. Okay, when you do radionuclide study, you can see parathyroid adenoma. Okay, and also you can see subperiosteal bone resorption, which is called as brown tumor. Okay, this is known as brown tumor on not histopathology, on direct gross appearance. Okay. Yes. So next we are going to hypoglycemia, which is topic number 100. So what is the definition of hypoglycemia in adults? It is less than 70 mg per dl. It is by definition based on lab value. So what is the triad that you get? Triad is very important. That is, one is symptoms. Symptoms is there is not Whipple triad, which means symptoms like sweating, anxiety. There can be finally patient can go into coma, but there will be anxiety, tremors, all these sympathetic system symptoms. So they will be present in hypoglycemia. Then there will be low glucose, and then immediate with the proper that is proper dextrose infusion, patient will revert back to normal. Okay. So what are the causes? Most common causes: insulin overdose, then sulfonylureas and alcohol. Okay. Next. It can occur in non-diabetic cause also, like sepsis can cause, renal failure can cause. What is endocrine cause? Like for example, cortisol deficiency, GH deficiency, or if there is Addison's crisis. Okay, you have seen this adrenal crisis. Okay, adrenal crisis means where this cortisol and aldosterone are decreased. Okay, so that is adrenal failure. Next, symptoms are tremor, sweating, confusion. Seizures can occur and coma can occur in severe cases. Okay, so how to prevent this? Immediate is oral glucose if patient is conscious. If patient is unconscious or not able to have glucose, then you will be giving IV dextrose, or glucagon also is another choice, but we prefer IV dextrose. Prevention is by adjusting insulin and meals accordingly. Okay, so you can see here low glucose less than 70, autonomic features will come. Okay, sympathetic features. These are neuroglycopenic symptoms. Okay, next. Whipple triad told symptoms along with low glucose and relief with the glucose supplementation. Then most three common causes you can see here: tremors. These are the symptoms, and these are the hormone deficiencies which can cause it. So important is postprandial hypoglycemia can occur after gastric surgery, because most of the gastric content is like diverted towards the intestine after bariatric surgeries. Second is insulinoma, where there is increased insulin secretion. It's a type of tumor which is seen in Men's syndrome. So increased insulinoma, increased insulin can also cause hypoglycemia. Next, third important thing, this is the most favorite question of examiners, that you'll be given a case scenario of a patient of diabetes who is also on beta blockers. He is on insulin and he is on beta blockers. So what beta blockers do is, beta blockers are sympatholytics, which means it will inhibit sympathomimetic symptoms. So even though patient has hypoglycemia and these symptoms of sweating, tremors, confusion and all, still that is masked because beta blockers act against it. So it will go unnoticed. Okay, so this is an important thing you should know. Next, glucagon is not given in alcohol-induced hypoglycemia, because in alcohol-induced hypoglycemia, first we don't give dextrose, but before that we give thiamine. Okay, because we'll see this in biochemistry also. What is the reason behind this? First we give thiamine, and after that only we give dextrose. Okay, because in alcoholics most commonly they are vitamin B1 deficient, and for glucose and glycogen metabolism we require vitamin B1 in the form of pyridoxal phosphate. Next, confusing seizures as epilepsy also can occur, because in your question you might miss totally that RBS values are given. Okay, next, Whipple triad is useful for diagnosis insulinoma, IV dextrose I have told you, all these things I have told you. Okay, so one more thing is, if insulin is high and C-peptide is low, that means it is factitious. Factitious means it is because of increased insulin dosage. Okay, because insulin is high but still C-peptide levels are low. And if recurrent, then you should order 72-hour fasting to see what is the cause, because there we take actually critical samples. Critical samples are the hormone samples which we take when patient goes into recurrent hypoglycemia to see for the cause. Okay. Next, monitor diabetics on insulin closely, check renal function before dose changes, and educate on early symptom recognition. That is what is required. Okay. Yes, so we'll go to next topic, that is hypoparathyroidism. So earlier we had seen hyperparathyroidism, and now we'll be seeing hypoparathyroidism. Yeah, so next topic is hypoparathyroidism. So basically in hypoparathyroidism there is low PTH, there is low calcium levels, okay, low calcium reabsorption but high phosphate reabsorption. This is because activity of parathyroid hormone function is to increase calcium and to decrease phosphate. Okay, that is the reason. As a result of which, these patients present with hypocalcemia only. Okay, and as a result of which they will have neuromuscular hyperexcitability. So what are the common causes? Most common causes post parathyroidectomy. As I told in previous slide, most common cause of hypoparathyroidism is post parathyroidectomy or thyroidectomy, because during thyroidectomy is also parathyroid glands are removed. Other causes are autoimmune causes. Then there is Diabetic syndrome, where there is aplasia of parathyroid glands. Okay, lab values you will find calcium is decreased, PTH is decreased, phosphate is increased. Okay, so remember PTH decreased is hypoparathyroidism. Rest calcium and phosphate are secondary values. Signs what you see: Chvostek sign and Trousseau sign. So these are signs basically of hypocalcemia. So what is Chvostek? Twitching of the facial nerve is called Chvostek when facial nerve is tapped near the tragus. And second is Trousseau sign, where you increase BP more than 20 than SBP, systolic blood pressure above that 20 you hold for 3 minutes, and you will see there is Trousseau sign or Acouche's sign. So symptoms are similar to that of hypocalcemia, only same, because means manifestation of hypoparathyroidism is hypocalcemia. So we get tetany, we get cramps, we get seizures, and there is QT interval prolongation, which I had discussed in hypocalcemia. I'm not going to discuss again. When there is chronic hypoparathyroidism, there will be basal ganglia calcifications. Remember this thing. Treatment for acute hypocalcemia is IV calcium gluconate, which should be given slow IV, or else it can cause cardiac arrest. Treatment chronic is oral calcium along with vitamin D3. Now, There are few types in this. One is pseudo hypoparathyroidism. So what is pseudo hypoparathyroidism? So in hypoparathyroidism, what happens? I'll just write this in pen only. Yes. In hypoparathyroidism, what happens? PTH is decreased, calcium is decreased, phosphate is increased. So in pseudo hypoparathyroidism, there are various types also in pseudo hypoparathyroidism. So in pseudo hypoparathyroidism, what happens is calcium is low and phosphate is high, just similar to that of hypoparathyroidism. But what happens is, paradoxically, PTH levels are high. So even though symptoms are similar to that of hypoparathyroidism, everything fits in hypoparathyroidism, but still PTH is unknowingly high. And this is the reason it is known as pseudo hypoparathyroidism. Got my point? So this is the basic difference between hypo and pseudo hypoparathyroidism, and why it happens, we'll keep it aside and we'll be reviewing it in pediatrics. Okay, basically there is mutation of a protein known as GNAS. Okay, as a result of which there is increased, there is defect in sensing calcium levels and all. Okay, so it is a separate topic. We'll not discuss it today. Now tell me quickly, this is the most important thing in your question that is required. Okay, so we'll just make a table: calcium, PTH, phosphate. Okay, this table will make. Now tell me what will happen in each of these. Okay, so first we'll see hyperparathyroidism. So primary hyperparathyroidism. Okay, primary hyperparathyroidism. What will happen to PTH? It will increase. As a result of increased PTH, calcium will increase and phosphate will decrease. In secondary hyperparathyroidism, what will happen? There is increased phosphate because of renal disease. Calcium will decrease as a result of what? As a result of with decreased vitamin D3. And what will happen to PTH? Because of decreased calcium, there is paradoxical increase in PTH. Now what happens in tertiary hyperparathyroidism? There is long-standing increase in phosphate and there is decreased calcium for a long time. As a result of which, PTH will be autonomous and it will increase so much. And as a result of which, this decreased calcium will be converted to increased calcium. And next we have hypoparathyroidism. So in hypoparathyroidism, what happens? PTH is decreased, calcium is decreased, phosphate is increased. And what happens in pseudo hypoparathyroidism? In pseudo hypoparathyroidism, this is the same, calcium and phosphate, like primary hypoparathyroidism. But what happens other than that? PTH will paradoxically increase. So this is exactly the table which you were finding it difficult to solve in every exam, and I have made it very, very, very simplified for you. Okay. So this is the overall thing that you should know. This much if you know, it is more than enough. Now there is one more thing known as pseudo hypoparathyroidism. And what is this everything you don't want? Just remember, in pseudo, here what happens in hypoparathyroidism, this one was high, no? In pseudo, everything is normal. There are features of hypoparathyroidism, but everything is normal. That is called as pseudo hypoparathyroidism. Okay. So there shouldn't be any confusion regarding this. Next, in a question you will get that a patient with hypoparathyroidism presented with tetany. Okay. But this tetany increased with hyperventilation. So what is the meaning of this? Why it happens? So basically tetany is because of hypocalcemia. And this hypocalcemia will worsen in case of respiratory alkalosis. Which means a patient has tetany and because of that panic or because of pain, he'll start hyperventilating. Then this hypocalcemia will further worsen. As a result of which tetany will worsen. So that is because of metabolic alkalosis. Okay, so respiratory alkalosis. Respiratory alkalosis worsens hypocalcemia, which increases worsens tetany. So hyperventilation exacerbates tetany. Next, autoimmune forms they are seen in autoimmune polyglandular syndrome. We also came across this in adrenal failure. In primary adrenal failure, we came across this. Okay. Next, giving vitamin D alone is not enough. We should supplement with calcium also. Okay. Next, missing QT prolongation is very fatal for you guys only. You will lose marks. Okay. Yes, Chostek side is seen in hypocalcemia, low calcium and low PTH means that is hypoparathyroidism. Acute therapy we had discussed. See, if PTH is low, calcium is low, primary hypoparathyroidism. If PTH is high, calcium is low and phosphate is high, that means it is pseudo hypoparathyroidism. Okay. Next, avoid rapid correction of calcium to prevent arrhythmia and to prevent cardiac arrest, and monitor magnesium levels also, because remember, any hypocalcemia that is refractory to calcium therapy, that is you give calcium gluconate but still patient is not responding, calcium levels are the same, remember always you have to see magnesium level, because magnesium is involved in the release of parathyroid hormone. So unless magnesium is there, parathyroid hormone won't release PTH and PTH won't increase calcium. Okay, so this one will also be low, this one will also be low. So if you supplement with magnesium in refractory cases, you will see that PTH release will happen, and as a result of which hypocalcemia will be corrected. I have seen this 2 such cases in my during my MD days. Okay, so that's why I'm stressing on this. Next, adjust calcitriol levels, because you don't want too much vitamin D3 because it can cause hypercalciuria that can actually increase propensity for calcium stones also. Okay, so I think I have explained everything here. Yes, we'll go on to next topic, that is osteoporosis. So what is osteoporosis? There is reduced bone mass and there are microarterial architectural deterioration. So Bone overall density is also decreased, and there is distortion of the architecture of the bone also, causing increased fragility to fractures. So what is the definition? Definition is bone mineral density T score is less than 2 point minus 2.5. Just remember this much. Not many questions are asked on this. Just remember the definition. T score, sorry, not Z score. T score less than 2.5 is diagnostic of osteoporosis. Common sites: back, that is vertebra, hip, distal radius. These are the common sites. Distal radius is typically seen in Colles fracture, which occurs in postmenopausal woman. Okay, so postmenopausal, senile, and it occurs secondary to other reasons, like for example steroid use. Steroid use also causes osteoporosis. So risk factors are age, steroids, low BMI, smoking. On lab values, you'll find normal calcium phosphate, everything is normal. Okay, but when you do DEXA scan, that time you'll find that the bone mineral density is less than minus 2.5. So that's why DEXA scan is recommended in all women more than 65 years. Treatment, what is treatment? Treatment is bisphosphonates, which are first line of drugs. Bisphosphonates. Okay, alternates are denosumab and teriparatide. So teriparatide is so what is the mechanism of action? Denosumab is basically rank L ligand antagonist. So rank L is present on osteoclast. It will promote osteolytic effect. Okay, so when it is prevented, there will be decreased resorption of the bone. Teriparatide is basically recombinant parathyroid hormone, but in contrast to action of PTH action is bone resorption. But here this recombinant PTH, it sits on osteoblast and it increases bone formation. Okay, that is mechanism of action of teriparatide. Bisphosphonates actually inhibit an enzyme known as farnesyl pyrophosphate synthase. These actually prevent osteoclastic activity. Osteoclastic, which means bone resorption activity, is decreased. Okay, so that's why bisphosphonates are the first line of choice, and along with this we give calcium and vitamin D also. What are the complications? Vertebral compression, vertebral fractures can occur. So DEXA is not used in acute fracture because there is no point. We want to see bone mineral density, mass density. Okay, so that's why we don't use in acute fractures. And bisphosphonates, it will take some mechanism time for its action to happen, so we won't stop it early also. Okay, next, teriparatide is contraindicated in bone malignancies because it has osteoblastic activity. It can actually increase risk of malignancies. So in bone malignancy, it is contraindicated. Second is glucocorticoids can cause rapid bone loss, and hence it is a prominent cause of osteoporosis. Next, FRAX estimate 10 years fracture risk. So FRAX is a clinical risk predicted tool that what is the risk of fracture occurrence in next 10 years. Okay, so this is just a clinical estimation tool. Just remember this much. Okay. Next, T score of less than 2.5 on minus 2.5 DEXA is osteoporosis. Bisphosphonate first line, and normal calcium level differentiates from osteomalacia, because in osteomalacia there is mineralization problem. Okay, here only there is decreased bone mineral density, but in osteomalacia there is decreased mineralization, and hence there will be decreased calcium levels also. Here there will be normal calcium. Yeah, so osteoporosis, calcium levels will be normal, but in osteomalacia calcium levels will be decreased. It's a very important part. Osteomalacia is mineralization, M for M. Okay. Next, if vertebral fractures are occurred, treat osteoporosis regardless of T score. Very important option, because in a clinical case scenario, question might come that the patient presented with vertebral fracture. Okay. Next, if steroid user is there, then you have to screen DEXA early on. Okay. And if renal failure is there, you have to avoid bisphosphonates. So weight bearing exercises improves bone mass. Okay, and ensure adequate protein intake in the diet. Monitor. Okay, one important side effect of bisphosphonates is osteonecrosis of the jaw, mandible. Okay, so this should be very important in your questions. Okay, so this is vertebral compression fracture that you are seeing over here, and these are the DEXA scan zones that you use. Okay, that's it in osteoporosis. And next we'll go to parathyroid gland overview of various disorders, summarizing one slide, which will be going on quickly. So primary hyperparathyroidism, commonly seen in parathyroid adenoma, calcium will be increased, PTH will be increased. Secondary, seen in CKD, calcium will be decreased, PTH will be increased, and phosphate will be increased. Hyperparathyroidism, low PTH will be there, low calcium, but increased phosphate will be there. And PTH role is to increase calcium and decrease phosphate. These are the effects of primary hyperparathyroidism. And this ECG levels will find short QT interval in hyperparathyroidism. And this pituitary adenoma that you see, this scan is known as SIADH scan. Okay, it is a radionuclide study. Long-term CKD, increased calcium because of increased PTH, autonomous activity is tertiary. Bone effect, periosteal resorption is seen in hyperparathyroidism, and this is a manifestation of hypocalcemia. So everything is what I discussed earlier. So I think I don't have to go through everything now. Yes, we'll go on to next topic, that is pheochromocytoma. So earlier we had seen adrenal gland cortex, so now we are going to see adrenal gland medulla. Okay, so it's basically a tumor in the adrenal gland medulla which increases secretion of these catecholamines, epinephrine and norepinephrine, which will have effect on brain, blood vessels, and the heart. So what are the 5 P's of pheochromocytoma? One is pressure, that is hypertension; pain, that is headache; perspiration, that is sweating; palpitations, and pallor. These are the 5 P's of pheochromocytoma. Now important, rule of 10 in pheochromocytoma: 10% pheochromocytomas are bilateral, 10% are extraadrenal, that is it is seen in these neural pathways. Okay, 10% are malignant, 10% are familial, 10% occur in children. Okay, and A before B, that is first you treat pheochromocytoma with alpha blockers and then with beta blockers. We'll see why. Okay, now So what is the origin of this pheochromocytoma? What is the original cells? These are chromaffin cells, okay? Chromaffin cells which are present in adrenal medulla. So rule of 10 I told you. What is the triad? Headache, sweating and palpitation. This is the hallmark triad that you have to remember. In House MD there is I think season number 2 episode number 1 which actually deals with pheochromocytoma, where you see a convict who actually has headache, who has sweating, who has palpitation, same triad is same. Next, crisis pheochromocytoma, that is basically there is paroxysmal hypertension. That is suddenly there will be hypertension, then it will be normal, then again suddenly there will be hypertension at some cases. So this is known as paroxysmal hypertension. Okay. Biochemically, the only test that is useful is plasma or urine metanephrine test. That is the only most sensitive test that is available. And on imaging, you will do MRI or CT of adrenal gland to see if there is any adrenal gland tumor. On treatment, first you will give alpha blockade because these adrenaline and noradrenaline, they have alpha action, they have beta action also. So first you will treat with alpha action, you will give alpha blockers, and then you will give beta blockers. Okay. And there are some drugs which can this phenoxybenzamine, it has both alpha plus beta blockade action. Okay, so it is one of the preferred drugs for pheochromocytoma. There are genetic links of pheochromocytoma also. MEN2 syndrome, 1 Hippolyndau syndrome, neurofibromatosis 1. All these are linked to pheochromocytoma. So treatment is surgical removal only. Okay. Yes. So I have discussed everything here. Yes. For metastatic disease, we use something as MIBG scan. Remember, system scan was for parathyroid adenoma, and here we use MIBG scan. Now, this is precipitated pheochromocytoma, that paroxysmal hypertension. It is precipitated by some anesthetic agent, so you should be very careful. And next, clonidine differentiates. Clonidine is a centrally acting, alpha 2 antagonist. Okay, it is centrally acting antihypertensive. Okay, so this will actually differentiate cases which are true pheochromocytoma positives from false positives. Okay, how mechanism and all, you just forget it. Just remember clonidine is one drug which can be used. Next, giving beta blocker before alpha. Okay, this is a deadly trap actually. That is because, so why we do this is, see what happens in pheochromocytoma. There is increased adrenaline, and second there is increased noradrenaline. So both these have action on alpha receptors as well as beta receptors. In alpha, you have action that is basically vasoconstriction. In beta 1 is for increased heart rate, that is tachycardia, and beta 2 actually causes vasodilation, okay, in the skeletal muscles. So this is the basic layout. Okay, I'll just write it down. Alpha is for alpha 1 vasoconstriction, beta 1 is for heart rate, that is increased heart rate, and beta 2 causes stimulation causes vasodilation in the skeletal muscles. Now what happens if you do alpha blockade first vasoconstriction will be prevented. So when vasoconstriction decreases, peripheral vascular resistance decreases, as a result of which BP will come under control. And at the same time, you are giving, after giving alpha blockade, then you are giving beta blockade to control heart rate, then you will decrease heart rate. That is normally how it should go. Now what happens if you give beta blocker first is, it will decrease heart rate, and second it will block this vasodilation, which means there will be unopposed vasoconstriction, and this beta blocker won't prevent this stimulation. Okay, this stimulation will continue by this adrenaline and noradrenaline. So there will be increased BP, sudden shooting of BP. That's why we don't give beta blocker first, we give first alpha blocker and then we go for beta blockade. Second, using labile BP as exclusion means in pheochromocytoma, BP readings are very fluctuating. So that shouldn't be used to exclude diagnosis. Next, relying on VMA levels only. VMA is vanillyl mandelic acid, which are basically excretion products of catecholamines. That alone has no significance. You should do urine metanephrine as well as blood metanephrine levels. That is more sensitive than relying on VMA alone. Okay. Next, triad, I have already told you, phenoxybenzamine is used as pre-operative drug because during surgery, one is because of stress, it can increase catecholamine surge, and second is some anesthetic agents can also increase catecholamine surge, because of which we give phenoxybenzamine pre-op. Okay. MEN2 is most likely associated with the pheochromocytoma. It's not MEN1, it is not MEN3, it is MEN2. If episodic hypertension is there, only on some occasions hypertension is there, think of pheochromocytoma. If catecholamines are normal, you will exclude the diagnosis, and if familial history is there, you will do genetic screening also. Now, one important thing is, this has discussion in pharmacology also. Tyramine foods, especially butter and cheese, these can actually increase levels of catecholamines, and these are basically MAO inhibitors. Okay, so MAO inhibitors along with these can actually precipitate catecholamine surge, so you should avoid this. Second is stress also triggers catecholamine surges, and BP monitoring closely is required in perioperative period. Okay. Next, what is the Zell-Bollen pattern? It is seen in histology in case of pheochromocytoma, and this is the MIBG scan of adrenal gland showing increased uptake. So that is seen in pheochromocytoma. Going on to next topic, that is pituitary adenoma, which we had discussed in detail during pathology also, but still I'll go through superficially. There are two types. One is functional pituitary adenoma, and another is non-functional. Functional means it is releasing hormones which are bringing out symptoms. Okay, so common is prolactin producing adenoma. So because of increased prolactin, there will be decreased dopamine. Okay, so this decreased dopamine will cause because prolactin inhibits dopamine. So when prolactin is increased, yes, dopamine is decreased. Okay, that is what you should remember. Second is there is something known as stalk effect. Stalk effect means with this pituitary stalk, no, that will block the release of this hormones from the hypothalamus. Okay, from here dopamine is secreted, that in turn causes prolactin release. Okay. So this pathway is inhibited, and that produces one important symptom because of the stalk effect, pressure effect. It will produce bitemporal hemianopia. So bitemporal means both the temporal areas. Okay, so this is bitemporal hemianopia. Okay, bitemporal hemianopia. Okay, that is loss of vision in the outer quadrants. So this is bitemporal hemianopia. Okay, next. Prolactinoma symptoms are mainly galactorrhea, amenorrhea. Okay, so these are prolactinoma symptoms. If there is GH secreting, growth hormone secreting adenoma, then features will be of acromegaly. If there is ACTH secreting tumor, then features will be of Cushing's disease. Diagnosis is via MRI, where you will see mass in sella turcica region. Treatment for prolactinoma is cabergoline. So cabergoline is basically a dopamine agonist. Okay, so it is dopamine agonist. So you know that dopamine inhibits prolactin. So that mechanism we are using here. Okay, dopamine inhibits prolactin. In non-functional, that is tumors which are not secreting hormones, so they will prefer surgical management, and in post-op care we will monitor cortisol, because there is tendency that patient might go into adrenal failure, that is adrenal insufficiency. So there is something known as pituitary apoplexy. Pituitary apoplexy means there can be profuse bleeding into the pituitary. So bleeding into pituitary can actually cause sudden necrosis of the pituitary, and sudden there will be collapse, a neurohormonal collapse. It will present as acute headache and visual loss. So this can be a question in exam. Second is because of stalk effect. What happens is this hypothalamus, there will be dopamine secretion. That dopamine actually inhibits this prolactin. When there is tumor or there is stalk effect on this dopamine is not secreted, as a result of which prolactin increases. This is known as stalk effect. Third is if TSH is increased, that means this is a type of central hyperthyroidism, and it is not peripheral hyperthyroidism. We had already discussed this. Next, there can be something known as drug-induced hyperprolactinemia also, especially with dopamine antagonists. Okay, dopamine antagonists like domperidone, okay, metoclopramide. Okay, so what this will do? These are dopamine antagonists. So as a result of which this will cause increased prolactin release, because dopamine inhibits prolactin, and inhibitor of dopamine will increase prolactin, and as a result of which in this case also we'll get galactorrhea and amenorrhea symptoms. Okay. Next, which are the examples for this? One more example is risperidone, which is an antipsychotic. It has antihypertensive action also, but it also acts via inhibiting dopamine. Next, delaying steroids in apoplexy is dangerous, because what happens is in apoplexy, because of bleeding and necrosis of pituitary, there will be decreased ACTH, that will decrease cortisol, and this cortisol will lead to acute adrenal insufficiency, which is very dangerous. Next, bitemporal hemianopia is a classical example which occurs when pituitary stalk is affected. There is pressure effect at the optic chiasma. Okay, so that you shouldn't miss out. So I have discussed everything here. Okay, if GH is excess, first thing we had discussed this in acromegaly also. First thing is to do IGF-1 levels. Okay, yes, we have discussed everything. So next we'll go to pituitary gland disorders, and here we'll be discussing things in detail. Okay, after that we'll be coming to SIADH. Yes. So now here, yes. So I have discussed all about this functional, non-functional, mass effect also we discussed, MRSL we have discussed, treatment for prolactinoma discussed, IGF-1 also we have discussed, posterior pituitary failure will lead to diabetes insipidus, that also we had discussed, and in addition to this acromegaly, Cushing's, everything we had discussed. Okay. Now, deficiency of more than or equal to one pituitary hormone is the definition of hypopituitarism. Okay, so either it should be GH, LHS, or FSH, TSH, or ACTH, any one of these hormone failures. Okay, so pituitary apoplexy I have explained, stalk compression, all this I have explained. I think I shouldn't go again into this detail. Next topic is SIADH. Okay, next we are going into SIADH. We just recently saw this pituitary deficiencies and all, hypopituitarism. So next we'll go to SIADH. Okay, so in SIADH, basically I said you it is not decreased ADH, it is increased ADH. Okay? Inappropriate hypersecretion of ADH. That is the meaning of this. Okay, so when there is increased ADH, there is increased ADH levels. Okay, so when there is increased ADH, there is increased antidiuresis, which means diuresis won't happen, as a result of which there will be decreased diuresis. Okay, antidiuresis. So there is decreased diuresis. So there is so there is decreased diuresis, and as a result of which urine formation is less. Okay, so we have decreased urine formation. Okay, so what happens here? See here, ADH, excess ADH, as occurs in SIADH, there is increased water resorption. That is, there is decreased urine formation. Okay, that is, there is decreased output of urine. That leads to something known as euvolemic hyponatremia. Now, what it is, we'll see. Okay, so SIADH is a disorder not of sodium metabolism. It is a disorder of water metabolism, which means selectively only water is stopped from excretion. That is, water is reabsorbed. So what will happen is sodium is not reabsorbed. Sodium will be wasted in the urine. Sodium will go out, but only water is reabsorbed. As a result of which, there won't be diuresis of urine, but there will be natriuresis, which means sodium will be lost in urine, increased quantities, but water won't be lost in the urine, water will be reabsorbed back. As a result, what happens? Volume will increase, because water is increasing in the body, volume will increase, at the same time sodium will decrease. So this leads to actually should have led to hypovolemic, because if water also would have gone out and sodium would have gone out, then total body volume will decrease. Okay, but now what happens? Water is being retained, only sodium is being excreted. So as a result, there is euvolemia, but there is hyponatremia. And remember, in hyponatremia there are three types of hyponatremia. One is euvolemic hyponatremia, one is hypovolemic. As a result of increased water reabsorption, we saw that there is decreased sodium apparent concentration, okay, because sodium is not reabsorbed. And as a result of which we'll get euvolemic hyponatremia. So there are three types of hyponatremia. One is euvolemic, another is hypovolemic, and third is hypervolemic. Okay. Now what happens in hypovolemic is there is decreased water also, there is decreased sodium also. In hypervolemic, what happens? There is increased water retention also, along with increased sodium retention also. Okay. So this happens in case of cirrhosis, in case of nephrotic syndrome, and all this occurs. In hypovolemic, what happens? You will basically see in case of diarrhea, in dehydration, in burns, in case of shock, there you will find hyponatremic. Okay. And euvolemic, there is only one condition, main condition that you should remember, that is SIADH. In every MCQ, unless proven otherwise, all euvolemic dehydration is SIADH. There are other some rare causes also, like hypothyroidism. It can occur in pseudo Cushing's also, but for you the most important is SIADH, which causes euvolemic hyponatremia. Okay, which means body status of volume is same. Like patient is not dehydrated, patient is not overhydrated. Overhydrated means third space. Like for example, SIADH is not there. There is no edema. Nothing is there. Okay. Next, let's see other. So one is volume status is euvolemic. It means there is no dehydration, there is no volume over volume state also. Okay. Now next important thing is serum sodium is low. Now why it is low? Because more water is getting reabsorbed, but sodium is not getting reabsorbed. As a result of which there is more water in the body, but less sodium. This is known as dilutional hyponatremia. Okay. So whenever you see the word dilutional hyponatremia, always think of SIADH. Next, what will happen in dilution? Osmolality will decrease, right? So serum osmolality is low. What happens to urine sodium? I told you, sodium is excreted. So urine sodium is high and it is more than 20, more than 30 is also true. Next, urine osmolality. What happens to urine osmolality? I told you, diuresis is not happening. So volume of urine is less. So urine will be low in volume, okay? But sodium is high. So what happens to osmolality of urine? Osmolality increases, which means it is a concentrated urine that you get, okay? So low urine output along with concentrated urine is seen in SIADH. And you should importantly rule out some other causes which can cause this, that is other endocrine causes should be ruled out, okay? Rule out all endocrine causes, rule out all cardiac causes. So there are 5 important diagnostic criteria for SIADH, and these are as follows. We have already seen. One is there should be euvolemia. Second is there should be low serum osmolality. Okay, serum osmolality should be low. Third one, there should be increased urine sodium and increased urine osmolality. Okay. Then fourth, there will be associated hyperuricemia. And fifth, other causes should be ruled out. Okay, other causes should be ruled out. So if you apply all this, then you'll get SIADH. Now, which are the causes of SIADH? What are the causes? One is any CNS infection, which is known to damage pituitary. Okay. Second is any lung tumors. In lung tumors also they secrete ADH. As a result, which you will get SIADH. Okay. Third, there are some drugs. Drugs mainly are SSRIs, carbamazepine, cyclophosphamide. Out of this, the most important I would suggest is carbamazepine. Carbamazepine you should know. Okay. One tumor which you should know is small cell carcinoma of the lung. So what is the treatment for this? Treatment is basic. If the body understands that there is less water, so it will try to preserve less water, right? So that is the reason behind mild SIADH. We do fluid restriction, which means when we restrict fluid, body will not try to conserve fluid, and when conservation of fluid is not there, the symptoms will decrease. The symptoms such as dilutional hyponatremia, all those will decrease. Okay, so one is fluid restriction. Second is if it is severe, then you give hypertonic saline and you will do slow correction. Now how to do slow correction and all, we will not touch that now. We'll see that under electrolytes. So if it is SIADH, ADH acts, ADH acts on V2 receptors. Okay, these are vasopressin 2 receptors present in the kidney. So we can give something which actually blocks these receptors so that ADH action doesn't take place. That is known as Vaptans, and we have tall Vaptan for this. Okay, tall Vaptan is a prototype drug. Next, post-operative, SIADH is common because post-operative, especially in neurosurgery and all, pituitary gland, there will be some damage, not damage exactly, but there will be some reactive inflammation taking place, as a result of which ADH is secreted in increased quantity. As a result, you will get SIADH. Okay. Next, hypouricemia supports diagnosis. I was wrong in one thing where we were saying, no, there is hypouricemia, okay, not hyperuricemia, decreased uric acid. Okay, sorry for the mistake. Next, rapid sodium correction can cause CPM. What is CPM? Central pontine myelinolysis. Pontine myelinolysis. Okay, myelinolysis. So you should be very careful whenever you are doing sodium correction, because here you actually have hyponatremia, and when you are correcting hyponatremia, you can only increase up to 8 milliequivalents per liter, 8 to 10 milliequivalents per liter in 24 hours, not more than that. If you go above 10, then it will result in this central pontine myelinolysis. I have actually seen a case of CPM because of rapid sodium correction. Next, assuming edema in SIADH, there won't be edema because there will be euvolemic state. Okay, only in hypervolemic we'll get edema. Next, using isotonic saline is of no use because we want to give hypertonic saline, because already there is dilution, right? And you don't want to create further dilution. So forget this. So low serum osmolality plus high urine osmolality is SIADH. Small cell carcinoma of the lung, ectopic ADH secretion. Fluid restriction is the first line. If euvolemic plus, again same thing. If seizure is there, give hypertonic saline. Seizure occurs because of hyponatremia, okay? Because of hyponatremia. If sodium rises too fast, stop correction, okay? Now, monitor sodium every 4 hours, look for offending medication, treat underlying tumor. What we are seeing now, this pons, around the pons, these lesions are there. This is central pontine myelinolysis, okay? So, two questions are very frequent. One is you have to diagnose what it is. Second is what is therapy treatment. And third is the central pontine myelinolysis, okay? These three things you should take care of. Now, next coming to thyroid cancer. This is a surgery topic, also a pathology topic. So we'll just touch superficially only, okay? So there are 4 main types. One is papillary carcinoma, which is the most common. Second is follicular. Third is medullary, and fourth is anaplastic, okay? So in papillary, the most common feature is orphan annii nucleus and Samoma bodies, which we have discussed in already in pathology. This spread is through lymphatic route, okay? Now very important, since follicular thyroid carcinoma is the origin is, it's not a soft tissue tumor, it's an epithelial tumor, right? So it is usually spread by lymphatic route. But there is one more major exception in thyroid carcinoma, that is follicular. So even though it is a epithelial origin tumor, still it is its spread is through hematogenous route, okay? Usually sarcoma spread through hematogenous route, but here we have follicular carcinoma which spreads through hematogenous route, okay? So there is capsular invasion, okay? In this, diagnosis is seen when there is capsular invasion, and treatment for this is radioiodine, okay? So papillary and follicular carcinoma, we use radioiodine. Next, there is third type, that is medullary type, where in medullary tumor there is calcitonin producing C cells. They'll have malignant potential, and this is seen in Mentu syndrome, okay? Calcitonin is produced by C cells, okay? C cells of the thyroid. Now this RECT mutation is responsible for this. We had seen all this in patho, so we don't give radioiodine in this case, okay? And last is very fatal, very dangerous, almost there is mortality always, that is anaplastic. It is occurs in elderly, so there is hoarseness of voice along with nerve infiltration, which is a major clue in your exams. And here main treatment is surgery only, okay? So yes, I think we have answered everything, okay? So in follicular carcinoma, you don't use FNAC because invasion will detect because of capsular invasion, and hence FNAC is of no use in this, okay? I think rest all we have discussed, yes. Medullary tumor will have amyloid stroma, okay, which we had seen in pathology. Follicular, we can't diagnose on FNAC alone, because if we want to see invasion, then FNAC is of no use. Lymph node spread doesn't occur in follicular because it is hematogenous, very important, okay? Next, orphan annii is seen in papillary, RET mutation is seen in medullary, hematogenous is seen in follicular, high calcitonin is seen in medullary, slow nodule in young is papillary carcinoma, poorly differentiated in elderly is anaplastic, okay? Now, ultrasound helps in stratifying risk, and TSH suppression post-surgery will be required, and so basically this means that you suppress TSH after surgery, because TSH can increase growth of this residual malignancy cells, okay? Residual cells whichever are there, it can increase growth. So as a result, you give thyroxine supplementation to keep TSH lower levels in post-surgical management, okay? Screen for MEN2 if you are seeing coming across medullary thyroid carcinoma. So this is orphan annii nuclei, okay, and this is Samoma bodies. These two are most important, okay? Next, we'll go to thyroid gland disorders in brief. Okay, so basically you have hyperthyroidism, under which you have Graves' disease and toxic nodules. You have nodular disease, which can be solitary or multinodular. Then there is hypothyroidism, and there is thyroiditis. Now, how to differentiate grossly in MCQ is hyperthyroidism, you will have all features of hyperthyroidism. In nodular disease, you will be given that on USG there is hot nodule or cold nodule, or on examination there were nodules felt. Okay, so that comes under solitary or multinodular goiter, and then you will have issue of goiter also. Now, hypothyroidism, you will get all these iodine deficiency signs, hypothyroidism signs and all. And thyroiditis is very important. It is painful, and you will get some viral infection history and all in that. Okay. Now, hyperthyroidism, Graves' disease, toxic nodules, you will see like this on radionuclide scan. In hyperthyroidism, TSH will be the first test. If TSH will be low, and there will be high T3 and T4 in case of hyperthyroidism. And most important is this anti-TPO and anti-TSH receptor antibodies. Okay, these are seen in Graves' disease. This is the autoimmune clue in this. Okay, hyperthyroidism. Next is hypothyroidism. You will have Hashimoto's, which is autoimmune restriction and iodine deficiency. So here you get goiter pattern. Because why goiter? Because TSH will be higher in this case, and TSH will cause increased growth of thyroid gland. So it can be diffuse or it can be nodular enlargement, and you will use ultrasound for nodule evaluation, and then you will do FNAC if the if it is solitary or multinodular, to see for further workup. Now, cold nodule means. So hot nodule means you will see that it is uptaking iodine, radionuclide iodine. As a result, it means it is forming thyroid hormone. Okay, it is forming thyroid hormone. Okay, thyroxine is formed. So these are mainly seen in hyperthyroidism. Cold nodule is mainly seen in malignancy. See here, it is not uptaking. Okay, on left side you can see the nodule is not uptaking iodine, radioactive iodine. So this has more malignancy risk. Okay, cold nodule. So treatment depends on etiology. Okay, in thyroiditis there will be painful thyroiditis, and it will be associated with high ESR because of some viral infection, post viral, and all it occurs. Next, high ESR occurs in subacute. Okay, next. TSH monitoring is essential in all types of thyroidism. Okay. Next, postpartum thyroiditis occurs, which is a transient thyrotoxicosis. Initially, there will be hypothyroidism, then there will be hyperthyroidism. So this is postpartum. Then there is subacute thyroiditis, which is mainly post-viral, and it shows high ESR. And then there is something known as renal thyroiditis, in which you get woody hard thyroid gland. Okay. So high TSH with low T4 is primary hypothyroidism. Low T4 is that. Painful gland with high ESR is subacute thyroiditis. Cold nodule you should see for malignancy. If it is painless thyrotoxicosis, always think of Graves' disease. If it is a solid nodule, FNSA is mandatory. You should see what is it malignancy, you have to rule out malignancy. And if TSH is suppressed, so if you see that TSH is low, that means T3, T4 will be high, which means it is producing some hormones. In this case, you do first radionuclear scan, you see whether it is a hot nodule or cold nodule. Only then you go for FNSA. Okay. That is the meaning of it. So TSH monitoring is essential. Ultrasound identifies suspicious features, whether it is cystic nodule, or whether it is single nodule, or whether it is multinodular, or whether it is solid nodule. Okay, everything will be diagnosed by ultrasound. Many nodules are benign and stable, so you don't have to worry. So most of the benign stable nodules will be hot nodules under radionuclide scan. Okay, so that's why radionuclide scan, uptake iodine scan is very important. So in Hashimoto's on histopathology, you'll see lymphocytic infiltration, and in subacute thyroiditis, you'll see granulomas. Okay. Next, we'll move on to thyroid storm. So what happens in thyroid storm is there is actually hyperthyroid crisis. So in a patient with hyperthyroidism, crisis occurs because of following triggering. One is infection, which is the trigger, surgery or trauma or racing or overheating body or agitation. So under trigger, there will be increased release of thyroid hormones. Okay, so these are the precipitant factors. Symptoms will be fever, tachycardia, delirium. All these are thyrotoxic features. Okay, so there will be very high T3, T4, and there will be very low TSH. Okay, in cardiovascular, it can also lead to atrial fibrillation, heart failure because of increased action of thyroxine hormones. Okay, in GIT, you will get nausea, vomiting, diarrhea, and all. What is the drug of choice? Yes, first drug of choice is beta blockers. I told this before also. Thyroid gland will stimulate sympathetic system, and for sympathetic response, we have one of the very good drugs, that is propranolol. Okay, and if there is agitation, then that means the thyroid storm is very severe. Thionamides in that PTU is preferred initially because it will block synthesis of thyroid hormones also. Iodine is given after PTU is given. Okay, because use of iodine is, it will decrease uptake. Okay, that is iodine, Lugol's iodine. It will decrease uptake of iodine, but for that we should first actually decrease release of thyroid hormones. So that is done by PTU. PTU will decrease release of thyroid hormones, and then iodine will be given later. Next, steroids, hydrocortisone also is given because it will reduce peripheral conversion of thyroid hormones. Okay. Now, blocking peripheral conversion, PTU also does, not only hydrocortisone. So that's why we prefer PTU when compared to methimazole. Okay. Methimazole doesn't convert T4 to T3, but PTU converts. So that's why P2 will inhibit release also, and it will inhibit conversion also. Now, what is this Birch-Wartowski score? It will estimate severity of thyroid storm. Just remember this. Next, high output failure can occur because of thyroid storm. Next, giving iodine before PTU is of no use. Remember, always first propylthiouracil, then we'll give iodine. Okay. Next, relying on lab values alone is also not important. You have to see symptomatic picture also, and urgent control is done using beta blocker. So PTU is first thionamide, iodine only after PTU, and steroids decrease conversion. So we give hydrocortisone also. If there is severe hypothermia, then also you can suspect thyroid storm because thyroid hormones, thyroxine actually increases the basal metabolic rate also. If atrial fibrillation, fever, thyrotoxic features are there, again it is thyrotoxic storm. And if agitation with tachycardia is there, you have to treat immediately with beta blockers. Avoid aspirin because it increases free T4 levels. Very, very important. Don't give aspirin in case of hyperthyroid storm. Cool the patient externally and identify and treat the precipitating factor also. Okay. So I think I have discussed everything. Yes. So here thyroid storm, how to identify: severe tachycardia, temperature high, out of mind, that is delirium, rapid that is atrial fibrillation, and mortality risk is also there. So how to remember PTU before I, that is first use PTU, then you'll use iodine. 4 piece of propylthiouracil is peripheral conversion block, preferred initially, and it is useful in first trimester of pregnancy. Okay. Avoid aspirin, cool the patient, look for infection, and monitor atrial fibrillation. Okay. Yes, next we'll go to last topic of endocrinology, after which we'll be going to renals, that is type 1 diabetes mellitus. Now, mechanism is simple. There is autoimmune destruction of pancreas, and as a result of it, there is insulin deficiency, and patient will be on lifelong insulin. So what is the mechanism? Autoimmune destruction of islet cells that produces insulin. So which antibodies are seen? Remember, GAD, IA2 and ZNT8. So GAD is glutamic acid decarboxylase. Okay, glutamic acid decarboxylase. Then IA2 is islet cell antibody 2, and ZN8 is zinc related transport 8 protein. Against that, antibodies will be there. Okay. So out of this, GAD is very common. So there will be marked fasting hyperglycemia, same polyuria, polydipsia, weight loss, and most of the times children present with and young adults present with vomiting. Okay, pain abdomen followed by vomiting. So there will be what will give initially will treat DKA, and if there is type 1 diabetes mellitus, will start patient on basal bolus regimen of insulin. Okay, so only insulin is the treatment of choice. There is nothing else. So how do you differentiate from type 2 diabetes mellitus? Here C peptide level is very low. In type 2, what happens? There is increased insulin secretion, and as a result of it, there is increased C peptide. But in type 1, there is no insulin only, so there is very low C peptide level. Okay, complication long term are the same as that in adult. There is nothing that is different. Okay, so there is something called as honeymoon phase. That is, there is partial remission once insulin is started. That is because once insulin is started, these cells, islet cells will slowly start to recover, and there will be transient phase where there will be some insulin production, and as a result of it, there will be a honeymoon phase. But during this phase, if patients stop taking insulin, then they will again go back to the same problem. So that's why patient should be counseled. Then there is something called as adult onset autoimmune type 1 diabetes, which is known as LADA. LADA means latent onset in diabetes in adults. Okay, so this is one counterpart of type 1 diabetes mellitus, which occurs in young adults. There can be viral triggers also. Now some infections like Coxsackie, which causes pancreatitis, mumps virus. Okay, they also can lead to type 1 diabetes mellitus. Okay, next, oral agents alone have no effect, no role in this type 1 diabetes. DK you shouldn't miss because it presents like acute diarrheal disease, like acute gastroenteritis. Okay, so many of the times DK is missed, and C peptide levels are always decreased. GAD, anti-GAD antibodies are positive. Absolute insulin dependence will be there. Low C peptide. If patient is lean, then having ketosis, then suspect type 1 diabetes. Ketosis is via urine ketone bodies. Okay, or there can be fruity odor in the breath. Next, if antibody is positive, confirm type 1 diabetes, and if illness triggers, there is risk of DKA. Like that is, most commonly patient will have some infection or some stress induced or some trauma. After that, patient will land up in DKA, or maybe fasting. Okay, so after that, patient will land up in DKA. So monitor for other autoimmune diseases, because type 1 diabetes mellitus is associated with other diseases also, where there is autoimmune link. Like for example, it occurs in celiac disease. Okay, it occurs in Hashimoto's, Addison's, Graves', pernicious anemia. So all these have link for type 1 diabetes mellitus. Okay, and main thing is education in patients. So this is what you say, autoimmune islet infiltration, and this is the basal bolus regimen that we give. We had discussed all this under type 2 diabetes mellitus earlier on. Okay, so it is mandatory that along with this endocrine, whatever you have studied, make sure you go back and solve diabetes mellitus QBank module. That is must. There are only 5 modules in medicine that you have to solve from systemic medicine. Okay, one is diabetes mellitus, second is hypertension, third is CKD and AKI. Okay, CKD AKI, fourth is MI, and fifth is stroke. Remember, in medicine, all questions made before INICET or NEET PG, everything will be focused on these 5 topics from systemic medicine. In general medicine, if you ask me, there are 3 topics. One is ABG, second is electrolyte imbalances, and third is infection. From these 3 parts in general medicine, always questions will come. Okay, so these 8 topics, QBank models, you have to solve. Okay, no matter what, we'll have to solve. Okay, so with this we finish endocrine, and we have finished endocrine around 1.5 hours. So total we have completed 4 systems so far: CVS, CNS, we have completed GIT with hepatology, and we have completed this endocrine. Okay, next we'll go ahead with renals. Okay, so renals will be a small topic, won't take us much time. So our entire task is to finish medicine in less than 10 hours. Okay, which I think is possible. So along with these things, you should also solve PYQs, whichever are available currently. Whichever you are solving, write the PYQ explanation below this page. Okay, so that you will have everything that is required under one PDF only, which is not more than 170 pages. So in this 170 pages, you will have everything that is required in medicine. Okay, so wait for the next PDF. It will be released in next 1 or 2 days. Next video will be released. It will be on renals. Okay, all the best till then.